PAE stands for Prostate Artery Embolization. And so prostate's obviously the gland. The artery is where we go when we do the procedure through a small blood vessel. And embolization is a term that we use to block something. So if you're in a car accident and you're having bleeding from an artery, or you come in with a gastric ulcer and you go to the hospital and you're bleeding, they oftentimes will call a doctor like us, an interventional radiologist, and we'll perform what's called an embolization. And an embolization is where we plug up or block blood flow to something. It could be an artery, it can be a vein, it can even be lymphatic ducts in certain situations, and even other structures. But basically, when you put all these words together and you get PAE, or prostate artery embolization, you end up getting a procedure in which we put a small microscopic catheter into the blood supply to the prostate, and we slow the blood flow down to the prostate. And by slowing the blood flow down to the prostate gland starts to shrink. When you have BPH or an enlarged prostate, the prostate develops too much blood flow. So you end up with many times normal the amount of blood flow you should have if you had a normal sized prostate gland. So let's say you have a normal sized prostate and your prostate flow is 1 on a scale of 1 to 10. As your prostate grows, that scale may go to 5, 6, 7, 8, 9, 10 times the amount of flow. And what we're doing when we go into the artery is we're injecting these little microscopic particles. They're like sand particles, okay? And they've slowed down the blood flow to the prostate. And now the prostate, if you will, is kind of starving. It's not a dead piece of necrotic tissue, but it's kind of starving for blood. And by starving for blood, that organ starts to shrink down because it can't live at this size anymore. And so that's what embolization does. And the procedure embolization, like I mentioned earlier, is done in trauma situations like car accidents or gunshot wounds. It's done in people with gastric ulcers. It's done in patients, women who have uterine fibroids or benign tumors of their uterus, where they have heavy menstrual cycles. It's done in vascular malformations, where in young kids who have abnormal connections between arteries and veins. So the procedure of embolization is not necessarily a novel idea. This has been around for 30 or 40 years. It's just that it's been applied over the past 10 plus years to the prostate, where now we can utilize this to shrink the prostate gland and reduce the symptoms from BPH. Prostate artery embolization, or the PAE, is typically covered by insurance. The devices we utilize for them, or the embolic devices, which is what they're called, these are little microscopic particles that we use to block the arteries. These particles have been approved by the FDA for use in the setting of prostate artery embolization for multiple years now. And there are multiple different devices that have been approved by the FDA for this procedure. So the procedure of the PAE can be performed really anywhere. It can be performed in an office-based laboratory setting, or an interventional lab in an office-based setting, which is how we perform it. It can be performed in a hospital-based setting, within a hospital-based interventional radiology center as well. So the place of it being performed does not matter. It's an ambulatory procedure, what we consider an outpatient procedure. In our experience, most patients prefer, of course, to not have to go to the hospital. In the more recent times, of course, nobody wants to go to the hospital at all. So really, I would say there's a big push and preference of patients, of course, to have it in an outpatient setting. It doesn't require overnight hospitalization or stay. It generally requires only about a two-hour post-operative period where patients are monitored and then they're sent home. So the procedure can vary in terms of length of time. Obviously, the more experienced you are with the procedure, it's a shorter time procedure than others. In our center, I can speak for us and our operators, it's somewhere between 30 and 45 minutes, but in some places it may be as long as 1 to 2 hours, depending on the time it takes them to perform the actual procedure. There are normal side effects after a PAE. So after a PAE, you can imagine the prostate's a little inflamed. So we get normal symptoms for a few days, somewhere between 4 and 7 days after the procedure are typical. So most men will experience urinary frequency, and that frequency means they're going to the bathroom more frequently than they were before. Mild burning when you urinate is very common. A mild amount of blood occasionally in the urine can be seen because the urethra may be inflamed. So if it's inflamed, it can pass some blood into the urine. It's very uncommon and rare to experience things like a fever or chills or night sweats. In my experience of a few thousand of these procedures, have not had patients call and say, we've had a fever after this procedure. It's an unexpected outcome, I would say, to have that. But the most common things, like I mentioned, urinary frequency, some burning when you urinate, maybe some blood in the urine, the sensation of wanting to have to urinate, those are common symptoms after the procedure. And they go away. So they're there for a few days. In terms of complications, right? Every procedure and surgery has any complication, right? We put a needle in the skin, even though we're not going through the penis and there's no risk, say, of impotence or incontinence, there are risks of things like bleeding. There's always a risk of infection. There's always a risk of something damage to nearby structure. But the reality is the risk of significant complication from a procedure like this is far less than 1%. So in a safety profile of urologic procedures, PAE has got to be the safest of those procedures. The prostate slowly shrinks after PAE. On average, it shrinks about 30% in volume. So if your prostate, for example, was about 90 grams beforehand, on average, it'll be around 60, 70 grams afterwards. Now, in terms of symptoms, those symptoms start to improve usually about 2 weeks to 4 weeks after the procedure. So it's a gradual improvement, generally by 4 weeks. In our experience, 90+% of men will say, oh, already urinating stronger. I'm already emptying more when I go and getting up at night. But the full effect of that prostate shrinkage does not occur for about 3 months. So it takes about 3 months for that prostate to completely shrink to its new baseline size. PAE is a very, I'd say, patient-friendly procedure. Why is it a patient-friendly procedure? We don't go through the penis to perform the procedure. It's performed through a twilight sleep, through one needle hole, either in the wrist here or in the top of the leg. So there's no incisions or stitches that we need to close these holes, just a needle hole. But really importantly, from a patient perspective, it doesn't have any effect on erectile function. So men do not have to worry about giving up erectile function when they get a PAE. This is an invariable risk of certain other urologic procedures, but the reality is in some of those procedures where they can carve out more prostatic tissue, the flow may be better. And take a TURP, for example. If you get a TURP, which is a classic rotor-rooter type procedure that's been around, like we talked about, for about 40 years, the flow rates from TURP can oftentimes be better than they are from PAE, but it does have that risk, as it does also have the risk of urine leakage or incontinence. Incontinence is also not a risk of PAE. So when I talk about patient-friendly procedures, what's nice about it is it's comfortable to go through, it should be generally painless, and there's really no risk of impotence or incontinence in men who have PAE. The recovery for BPH is generally goes like this. So in the first 2 to 4 days after the procedure, men will experience that most commonly that frequency that we talk about. So urinary frequency that's worse than baseline. Out to about 7 days, they may have some of this urinary frequency where they're going more than before, and some burning when they urinate, which is normal, or maybe some blood in the urine. So that's that immediate first week recovery. When they leave the office with us, they go home about 2 hours after the procedure. The next day, they can go back to driving a car. If they want to go back to work, they can go back to work. Yes, they may have some of these irritating symptoms, but they can certainly work as long as they're not going out and lifting very heavy objects. So that brings me to their physical function. So physical function-wise, next day if they want to go for a walk, go to the mall, go to dinner, restaurants, etc., normal activity is fine. But if they want to go on lengthy walks, get on a treadmill, lift weights, heavy exercise, etc., say lift things that are 30, 40 pounds or heavier, then we like them to wait 5 to 7 days. The reason we have them wait 5 days is because if we've gone in through the top of the leg or through the wrist, we've gone in through a blood vessel. And we don't want them to get home and get irritation from that spot or have any bleeding in that area. And generally, if they go home and just follow that instruction of normal activity, they should not run into any problem. So that's that immediate recovery, going back to work, etc. Normal sexual activity, there's no real restriction to sexual activity. So if they want to wait a few days until some of that frequency is worn off and they have a scab over either one of these sites, that's completely fine. They can wait just a few days to have normal sexual activity as well. There's no limitation from that standpoint either. Two great questions is one is how effective is a PA and how long does it last? So let's start with the first one. So how effective is it? This varies obviously a lot based on institution to institution, right? It's going to be based on the technical expertise first. Did the physician get into both prostatic arteries? Did they inject enough of these beads to slow down the blood flow? And so how effective were they in actually the treatment itself? So as long as the procedure was done, I would say, to a high enough successful standard, then at our center, I can speak to our success rate. The success rate is somewhere between 90 and 95%. By that, I mean 90 to 95% of men do not need another treatment. They don't desire another treatment. They're satisfied with their results. They've either come off medications, right? Or they've had at least a significant reduction in that scale that we talked about, where a severity scale of how severe their symptoms are. So it should be a very high success rate. There are people who fail, so it's important to consider that 5 to 10% of men fail. With PAE, they generally do not get worse, so that's a nice thing. Even though you have a failure rate, they shouldn't be worse off than where they started after their recovery, which is nice. They can still go on to get another treatment option, so that's good as well. In terms of how long does it last? So this is a very good question. We have 5 and 7 year data from our prostate artery embolization studies, which is actually longer term data than many of the other urologic procedures that are available now. And the data has shown that the men who get a success, so obviously leaving aside the people who failed initially, but the men who get a success, there's about a 10 to 15% roll-off or failure rate at 5 years. Now that doesn't mean all of these men need to get treatment, because the vast majority of these men are still doing great. And then the men who fail, some of them may be fine with just getting back on medicine. Some may just alter their lifestyle. Some may choose to have another procedure. And that second procedure could be a PAE, it could be a Urolift, Resume, aquablation, it could be anything. So the reality is it's got a very low recurrence rate over that time. The gold standard, in my opinion, of recurrence rate is still going to be TURP, or transurethral resection of the prostate. If a patient is willing to accept those, those side effects, which are invariably there, like retrograde ejaculation or the risk of incontinence or erectile function, then they will definitely have a higher long-term success rate. Their initial success rate actually is pretty similar between TURP and PAE, but the long-term, say 10-year success rate, may be slightly higher for TURP or rotor-rotor type procedure, but that's to be expected, right? If you take a little bit higher risk and you sacrifice a few things here, I mean, it's a little bit more of a risky surgical procedure, but the reality is there are patients who we do have to refer to TURP, who may not be an ideal candidate for PAE. So with all the urologic procedures, they fundamentally work different, right? So some may be a cutting type procedure, like take a prostatectomy, where we remove the whole prostate. So that's just, let's get rid of the whole prostate gland. Certain other procedures like TURP or aquablation, right? So aquablation uses a water jet to remove tissue. TURP may use, it's like a loop device to basically take out the tissue. But the reality is they're removing tissue with those devices. Then you have devices like Urolift. They use staples or clips to push aside tissue. So they're trying to like spread an opening wide so the urine can flow through. And then you work your way into Resume. Resume is a technology which uses steam or water vapor to basically heat up that tissue, and basically that surface heat is allowing that tissue to basically dissolve or resorb and then widen that passageway. And last, you have PAE. So prostate artery embolization is a procedure where you're not doing anything from, I would say, the urethra or removing that tissue. If in a way you're by blocking the blood flow or slowing the blood flow, you're naturally allowing the prostate to shrink. So the tissue actually shrinks wholly. So as the entire gland shrinks, you get its effect. So they all work in really different mechanisms, but prostate artery embolization works by that sort of whole gland methodology by shrinking the entire prostate. The comparison of PAE and Urolift is actually interesting. So Urolift has a real sweet spot of patients. It's best performed on men who have prostates between, say, 40 to 50 grams and, say, 80 grams. When they get too large, it can be difficult to place the clips, or the number of clips you need to place with the Urolift device can be both challenging, like I mentioned, in terms of location, but also the number you have to place may be increased. So it's not as effective in men who have larger prostates. There are some more recent clinical studies that are demonstrating that it can be, but those are obviously maybe in select high volume, very experienced users who have that experience. And then if you look at PAE, for example, its general effectiveness is in men who have 40 to 50 gram prostates and larger, but there's no upper size limit. So when you look at PAE, there's overlap with Urolift in who's a candidate in that 50 to 80 grams, but certainly in the men who are over 80, PAE is probably a better option. The longer term data, there's more longer term data with PAE than Urolift in terms of being favorable. And if you look at the comparative studies of Urolift versus TURP and PAE versus TURP, PAE has more clinical data that's to date been published. So in terms of what's available in the scientific literature, there's more scientific literature that favors PAE over Urolift, but there's never been a head-to-head that compares the two. So that's really important for patients to understand. A lot of what we do with our data is really try to extrapolate some of this information to compare things. And this goes back to why it's important to, when you see your doctor, to understand that you should be offered all options, or at least in their practice do they offer all these options, because that's going to give you a real truthful opinion of which is going to be better for you. The most common questions I get asked are, does it affect your sexual function? So the answer, like I mentioned before, was it does not affect your sexual function in terms of you'll be able to have an erection and orgasm before and after a PAE, no different. There are a small number of men who actually report improvement, but the reality is there shouldn't be a negative change. The next most common question I ask is, what happens with the beads? Do the beads travel anywhere? Do they go anywhere? Do they break down? So the beads that we utilize to inject in the arteries, they come in different varieties. So we have at our disposal absorbable beads, the types of beads that break down and can get absorbed. We have beads that are permanent, that stay there forever, and they might have some molecular breakdown on the surface, but invariably they are permanent. But the reality is, even if you look at the permanent beads, once they're in the prostate, they don't travel anyplace, they stay in that location, they may have some surface erosion to them. The amount of beads that are injected are probably less than a teaspoon in the entire prostate gland. And the reason why it's so small is because the capillaries in the prostate are so small. They range in size from, say, 70 micron to, say, 400 micron in size. So they're less than a millimeter in size. And so when we inject these beads, you only need so little. And then the beads wedge into these arteries. So they're wedged in, and there's no outflow for these beads to travel to once they've already been placed successfully there. So that's a very common question I get asked about PAE. And then I'd say other things that people ask are usually, how many of these procedures have you done? They want to know that you're experienced. I think that's a very important question to ask your physician. And that should not be just specific to PAE. Of course, it should be really for everything. And then they really want to know about, when am I going to feel better and how long is it going to last? So the big key with that is, like I mentioned earlier, is this very low recurrence rate at 5 years, but you could get it again if need be. We talked about earlier how invariably the prostate will grow in all men, no matter what you have done. And I think, when am I going to notice the improvement? So that improvement, they'll first start to notice that improvement, like I mentioned, between week 2 and week 4, but they're really not going to see the maximal effect till about 3 months afterwards. But oftentimes the most they notice is that dramatic first 4 to 6 weeks where they say, wow, this is such a difference from where I felt before. PAE in its current form is not being used to treat prostate cancer. There is a unique circumstance in which we do utilize prostate embolization or prostate artery embolization in patients who have prostate cancer, but it's not the primary therapy. The primary therapy, or the mainstay of therapy, is still centered around surgery and radiation and medical therapy, really, or hormonal therapy, as the mainstays for treatment of prostate cancer. But there are certain instances in men who have prostate cancer where we do prostate artery embolization. So I'll give you some of those examples. So men who've had prostate cancer and have previously had radiation or treatment and now have symptoms of BPH, those men can get further reduction of their prostate with PAE, and it's been shown to be effective, and we do that not infrequently. And the other patients who can actually benefit from prostatic artery embolization are those patients who are going to get radiation therapy and have a very large prostate and symptoms of BPH, and you want to do it before they go get radiation. And why do I say that? Many of the men who go on to get radiation, if they have severe symptoms and a very large prostate, meaning over, say, 70 or 80 grams, those men have a high likelihood of ending up in urinary retention where they may require a catheter to drain their urine from their bladder. So if you do the prostatic artery embolization before their treatment, you can reduce the size, reduce the swelling of the prostate, and reduce the chance of that occurring. So although PAE is not primarily for the treatment of prostate cancer, there is an overlap amongst those two. In terms of training for prostate artery embolization, the specialty that performs it are vascular interventional radiologists. So these folks have gone through internship, residency, and then a subspecialty fellowship, which is advanced training in interventional radiology. Following that, for interventional radiologists, I would consider to be adept at doing prostatic artery embolization. They usually attend courses like CME courses and training and seminars. They may do proctorship or mentoring with certain centers which are high volume. It generally takes most interventional radiologists at least 50 cases before they start feeling very comfortable doing prostatic artery embolization. So at our center, for example, at Prostate Centers, we have physicians who visit and get training. Our own physicians who come and work with us, for example, who are within our practice, they have to go through at least 100 cases before they're even considered. So we probably set standards that are higher, but we're also doing a very high volume of cases. But absolutely, interventional radiologists as a whole, it's within their wheelhouse, if you will, because they have this base fundamental training to be doing embolization procedures around the entire body. in order to prepare for a PAE, there's really nothing I would say in particular you have to do. There may be some preoperative testing that the interventional radiologist may have you get. For example, if you're on a blood thinner or if you have kidney disease, they may issue some laboratory tests to make sure that your kidney function's okay or that your blood is not too thin to have a certain procedure. But generally speaking, there's not much in the preoperative preparation. There's no bowel prep to take like you would for a colonoscopy. The only real consideration that all patients should remember is that before the procedure, if they're going to be getting moderate sedation or a sedative medicine for the procedure, what we call a twilight sleep, we generally do not have them eat or drink for about 6 hours before the procedure to reduce any risk of nausea or vomiting during the procedure. But it's a very simple prep. There should really be nothing else. Generally speaking, if they're going to one of these appointments, they usually go with a ride or have someone drop them off and pick them up because, of course, if they're getting sedation medicine, they can't drive themselves home after a procedure. I think probably the most important question I think patients should ask with respect to PAE should be, if they're not asking, is what's your experience level with this procedure? How long does it take? And what is your personal success and failure rate? Because I think it's very important to know everybody's individual, right? I may be different than my partner and another practice or another hospital. I think that piece of information is really important for patients to understand. And again, that works for any procedure you're about to undergo. I think that's probably really important. The other key things to make sure that you ask a physician, and interventional radiologist in particular, is what other options might I be a candidate for? Because invariably, if you're a candidate for PAE, you probably are a candidate for HoLEP, Resume, Urolift, prostatectomy, all of these other options. We want to know. So when you ask your doctor these questions, you want to know, do they have a good fundamental knowledge of, am I a candidate for the other procedures and why might this be better? So if patients don't ask me, am I a candidate for another procedure, I often will tell them, listen, you are also a candidate for this other procedure. Would you like me to go in depth into why you could get this? But this is what's involved in that procedure. The procedure, the recovery, et cetera, complications, or are you satisfied with just having this procedure and knowing on a surface what that procedure is? Because that's a very important question for patients to ask. So if you don't ask, I think it's obviously the impetus is on us to make sure we explain that, but if I were a patient, I would definitely ask those questions.